Good afternoon, everyone, and welcome to Wednesday Wellness, a free live educational series by Trinity Health. We are thrilled that you have joined us this afternoon as we discuss gynecologic surgeries and what to expect. Before we get started, we have a few notes we would like to share. First, your cameras and microphones have been turned off to ensure a smooth experience. If you have questions during the presentation, please use the Q&A chat feature at the bottom of your screen. Questions will be addressed at the end of the presentation. And lastly, today's webinar is being recorded and a link to the video will be shared with you via email over the next several days. And without further ado, I am pleased to introduce Dr. Erica Sickinga, a board-certified OBGYN with Trinity Health Medical Group.
Hello, and welcome to Wednesday. Wednesday is my favorite day of the week in most cases, so get her done, right? Today, I'm just going to review a couple of common gynecological surgeries, just so the names mean something to you in the future if you ever have this conversation with either me or your gynecologist. And then at the end, I will review something called enhanced recovery after surgery, and then I'll open it up to questions. I think our moderator has a few questions up her sleeve, but if anybody has questions on top of that, we'll address those as well. So first, a little introduction to me. I am from the center of the state, a small town called Carson City. We don't have a stoplight. That's how big it is. But we do have McDonald's, so it got in the end of my life there. And I hear we're getting a Taco Bell now, so that's pretty exciting. I went to Hope College in Holland for undergrad. I then graduated and went to MSU, Go Green, for med school. At the end of medical school, through the Michigan State College of Osteopathic Medicine, you choose a base hospital. And one of the base hospitals in Michigan is Muskegon. It used to be out of the Oak campus for all of you who remember those days. And so that became my home. My intentions at that time were to go into family practice so that I could see and grow a relationship with a lot of people. Once I got into my rotations, I did an OB rotation where I found that delivering babies was magical. In Muskegon, the family practice residency also included OB, so I thought I could do both of those things. And then I got into the surgical world and realized that I actually belonged in the OR. So I switched over, and luckily the program here accepted me. And I finished my residency here. I then took a job at OB-GYN Associates. We are still in the same building, which I lovingly refer to as Hackley Ruins, because it is over where Hackley used to be attached to, which now is a school. So the landscape has changed quite a bit, but I'm still there. We now do our surgeries and deliveries out of the large tower on Sherman, Trinity Health, Muskegon. And it used to be Mercy Hospital. So we've done the Oak campus, Hackley, and now our home is here. So that's a little bit about me. If you have any questions about me, I'm glad to answer them too. But obviously, we're here to talk about gynecological surgery. So let's get busy into that. So here's a list, definitely not exhaustive, of the different surgeries that are most often coined gynecological. So we have hysteroscopy. Usually it includes a dilation and curettage, because when we're doing a hysteroscopy, we are what I lovingly also refer to as a search and rescue mission. So we're trying to figure out what's inside of the uterus and then probably sample it and send it off. Ablations are pretty common procedures that we do. A LEEP, a cold knife cone, laparoscopies. This can include just a diagnostic laparoscopy where we're just in there looking. It can also have ovarian cyst removal, evaluation and removal of endometriosis. At times we remove tubes, which interestingly, during my career, because I've been doing this for a little bit of time, we have found that some ovarian cancers actually start in the tubes. So if we are doing another surgery, an endometriosis surgery, an ovarian cyst surgery, we can also talk about removing tubes if people are done childbearing to decrease their ovarian cancer risk. Laparoscopy can also be done with something called the robot, which the robot that we have here, we actually have two of them, is called the Da Vinci. The Da Vinci robot is an apparatus that we click our laparoscopy instruments into, and then instead of standing right next to the patient and reaching over to squeeze our laparoscopy instruments, we click them into this robot, and then we can sit down and manipulate them from a couple of feet away on the console. Pretty fun invention, and has an amazing camera, which has really good visuals and allows us to pick up on things that we probably would have missed straight stick. And the dissection ability is down to much finer, so we can tackle more difficult jobs safer. Myomectomies is a procedure when people have non-cancerous tumors of the uterus called fibroids or myomas, and we can remove those and leave the uterus in place. Oftentimes that is reserved for large fibroids in the setting of infertility or concerns for fertility. Hysterectomy is removing the uterus. Then there's some prolapse surgeries, vaginal reconstruction, urinary incontinence surgeries, and then there are some others in there. This is a pretty good little picture to show you guys what happens during a hysteroscopy. The depiction here kind of looks like that's probably gas, but we tend to use liquid. So the uterus itself is a deflated water balloon, so you can't see anything. It's dark in there and it's compressed. So we can put a small camera right through the cervix and inflate it with liquid, water, saline. There's different medias that we use, but most of the time it's saline. That allows us to open up the cavity, and then there's a light on the camera so we can see all the things. So this would be if we're looking for a thickened endometrium, if there's something that showed up on an ultrasound, if we're having abnormal bleeding, things like that. So the good news here is that we don't make an incision. We just use the hole God gave us to be able to identify if there's any pathology going on in there. This is a picture of a device that also has come about since my career started, which was 20-ish years ago. I'm going to start changing my ish to maybe calling it 15-ish, or maybe I'll just call it ish years ago. We don't need to talk about how old we're getting in life, right? Time flies. But it's called the MyoSure. This is done during a hysteroscopy. So this is kind of a sideways picture of one of those inflated uteruses that we just talked about. This device right here has a channel that will bring fluid in and then remove pathology. So the pathology in this instance is this small white nodule here, which probably is a fibroid that they're trying to show an example of. Now, this used to be a video, but I guess it didn't carry over. So you'll just have to trust me on it. Or you can Google videos on MyoSure and they'll show you a picture of how nifty it is. It's a very cool device, and I think it has changed the recovery for hysteroscopy D&Cs to a much gentler and less crampy recovery that happens. This is an ablation. We usually combine this with a MyoSure as well. So we take a peek inside the uterus first, then we remove that camera and light that we showed on the previous pictures. Then we insert this device. This one is a NovaSure. There are multiple different brands and types, but the NovaSure, if you've ever heard of that name, kind of looks like if you were to take a piece of paper and make a Chinese fan out of it, where you fold it back and forth and fold it back and forth, so then it opens up. So you place the device inside of the uterus, you open it up. It has a computer that feeds back with the goal of trying to burn about 4 millimeters of tissue, which should be the endometrium, which is the part that grows and sloughs off each month for someone's periods. We then close that fan up, pull it back out. The goal of this surgery is to help people that have periods that are difficult for them with the volume of blood. So in most of our lives, if we have a scar that forms, we hope that the scar doesn't form very well and our body heals it over. But in this case, we're hoping that the scar is robust. So if the body reheals some of that endometrium, we'll continue having periods. But hopefully we have destroyed or scarred a fair amount of the cavity, if not the whole cavity, to decrease the volume of blood that's lost. This procedure is called a LEAP. This is for patients that have precancerous cells on their cervix. So this is a picture of a cervix. I always describe it to people as looking like a donut. And the donut hole is oftentimes where the pathology is for most types of cervical cancer, because it's where you change from this light pink type of cell into a brighter pink glandular cell. So we numb up the cervix, and then we use this hot wire to remove the surface and this part of the donut hole. We send that off to pathology to make sure there isn't any hidden surgery. We're also hoping that it gives the body a little boost to fighting whatever is you're losing, in that case, if we're headed towards cancer. A cold knife cone, which I mentioned back at the beginning, it's a very similar procedure, except we aren't using a hot wire. We're using a scalpel to remove that same portion of the cervix. Laparoscopy is the next one we're going to jump into. I'm going to pause just for a second to kind of delineate a little bit here. These previous ones that we talked about here are usually done under a pretty light and quick anesthesia. Depending upon the health of the patient, sometimes we can use something called a MAC, which is monitored anesthesia care, which is where we put you to sleep, where you don't feel or remember anything, but you're still breathing on your own. The recovery from that is a little bit quicker. Obviously, if we're counting on you to breathe on your own, you have to have good breathing. So if there's any breathing issues, we'll move on to something called a general anesthesia. Once we jump into something called a laparoscopy here, you have to be put under general, because you can't breathe on your own if we're going to be inside your abdomen like that. So a little bit deeper anesthesia, and then it takes a little bit longer to recover from, just to get out of the hospital, only because we have to wait for your body to digest all of that anesthesia there. But it also is a fairly quick recovery from that as well. So this is a body kind of cut in half right down the middle like this. So we're looking at half of the abdomen there. It's probably the patient's right leg that you're seeing down at the bottom here. And then straight through, which makes you cringe a little bit. This is probably your right butt cheek. The left butt cheek is missing in this picture. And you can see some depictions of the relationship between your bladder, uterus, rectum, and then the rest of the bowels, which are up in here. So here's the bladder. This is a uterus. That right tube and ovary are still present. And then laying right across the bottom is the rectum. This is where you would pee from, right here. This is where the menses blood would come from, right here. And then where a bowel movement would come out. So that's the relationship in them. The inside of the abdomen is a dark, deflated balloon as well. So we have to inflate it. In this case, we inflate it with gas, carbon-based gas. And then we put this small device right through the belly button, or near the belly button usually, that has a light on it so that we can take pictures. If we end up needing to do anything with pathology, like in this case, it looks like they're headed towards the tube, or remove an ovarian cyst, or do a hysterectomy or myomectomy, then we put in another couple of ports that act as our hands. So the camera acts as our eye, and then the side ports act as our hands, so that we can do surgery through holes that are usually 5 to 8 millimeters big. So much better recovery when it comes to that when we have a smaller incision. Here's a little depiction of the different places that fibroids can be. Remember from the beginning of this talk, we talked about they're non-cancerous tumors of the uterus. They can be really small and right in the wall. They can be just touching on the cavity. They can be dangling in the cavity. They can be right outside of the cavity, or these ones are called pedunculated, meaning that they have a little stalk, but they're not affecting the uterus itself. So removing them would be a myomectomy. Hysterectomy, in most cases, we're trying to get to minimally invasive so that we can get people back on their feet and feeling as good as possible, as soon as possible, with the least amount of discomfort. So we call those minimally invasive surgeries that would be done laparoscopically or down at the bottom vaginally to remove the uterus, and then open if we have pathology that is concerning or large enough that we can't fit it out through a minimally invasive approach. Then we'll make a larger incision in the abdomen, which is how they all used to be done way back in the day, like before me and my ish years of being in practice. Making an incision kind of like a C-section scar, or sometimes vertically, to get that done. So this is something that I thought I would toss in here real quick, just because there's often a lot of confusion with the names of hysterectomies. So people often will talk to me about partial, total hysterectomies. So the different nomenclature that we have is a partial hysterectomy, a total hysterectomy with salpingectomy, or a total with salpingo-oophorectomy. So to have a total hysterectomy, that encompasses the uterus itself with the cervix, because you can see how that kind of looks like an upside down balloon. The cervix is the portion that you would blow up. So that delineation is not quite as perfect as it is in this picture, but if we're doing a total hysterectomy, we're taking out the uterus and that cervix. If we're doing a partial hysterectomy, we're oftentimes leaving the cervix behind. For a little while, probably about 15 years ago, that became a pretty common surgery. ACOG has since come out and said there probably isn't a good reason to leave the cervix behind because there's always potential for cervix pathology. We also oftentimes will have irregular bleeding because this little pink lining right here in the cervix can still make its way out. If we're talking about a total hysterectomy, remember that's the uterus and the cervix, with a salpingectomy, we're also taking these fallopian tubes out here. And again, at the beginning of our conversation today, I talked about how some ovarian cancers actually start in the tubes. So we are no longer leaving those tubes behind. They are used for fertility purposes. So if we're trying to get an egg to be released from the ovary, picked up, meet a spermie right along here, and then implant here, that would be the reason for the tubes. So if the uterus is no longer present, there isn't a function for the tubes except for to cause trouble. So we take those out as well. So that would be called a total hysterectomy with salpingectomy. Oftentimes we say bilateral salpingectomy because we're doing both the right and the left side. We wouldn't want to leave one behind. If we change the wording to total hysterectomy with salpingo-oophorectomy, then we're removing that uterus, that cervix, the tubes, and the ovaries that are present there. That would change us into a menopausal state. I'm going to go mobile with you guys, so we're going to go on a little adventure because the room that I was going to use is. So I'm going to take you guys on a little walk and we will keep on talking. So excuse my jiggles here. I hope you don't get motion sick, but I'm not going far, so don't worry. The next picture that you'll see here is referring to some incontinence and incontinence surgery. We do these in combination as general gynecologists with urology as well as urogynecology, so pretty common to hear those names there. This is an example of one urinary surgery where we place this small sling right here to support the bladder neck for things like urinary incontinence. So all of the famous coughing and sneezing and leaking. There's some other portions to that we can talk about in the office, or you can talk about in the office as well. But this is a little. This patient is also cut in half right down the middle, kind of like our last one. So you got the right leg over there, and then the right butt cheek is down here, and then this is halfway through. This one did not cut the bladder and the uterus in half because it left the uterus intact. It also left the ovary there. So we have both of our ovaries in this picture, but we sliced right through the bladder to show a picture there. There's also prolapse and reconstruction surgeries, whether the uterus is dropping out, the bladder is dropping, the rectum is bulging into the vagina. Those are some surgeries that also are shared amongst general gynecologists as well as urogynecologists. So we work together in evaluation during that appointment that we evaluate to decide what the best route is and the best person is for you to have the best outcome possible. Now I'm going to touch on something called enhanced recovery after surgery. Depending upon whether you're a Swiftie or not is how you would pronounce the acronym for that. So either ERAS, or if you're a Taylor Swift fan, maybe you say it's the ERAS. So Gynecological World is in their ERAS tour. There's a lot of surgeries that have their own enhanced recovery protocol because our goal is to do just that, enhance your recovery. We want people to come out of their surgery feeling as good as possible with the least amount of discomfort and get back on their feet and back to their lives, because we know everybody just has a really, in most cases, crazy life going. So we just want you to feel as good as possible. So if you hear that ERAS or enhanced recovery or ERAS, depending upon who you are, wording, that includes these 3 steps that is depicted right here. We try to get you in what we call prehabilitation. So we're trying to get you to be as healthy as possible before your surgery, so we know that that won't be taking us down in your recovery So optimizing people's weight, their sugars, their smoking, things that could inhibit their recovery. We try to work with their primary care doctors to get them just as good as possible beforehand. We really want to get you as educated as possible so you know exactly what's going to happen and how you're going to feel afterwards. Hopefully, everybody's body responds a little bit differently. So there's wide range of normal, but knowing what that wide range is. We also work with you on using a certain soap to decrease the bacteria that's on your skin. And then there is a pre-surgical drink that many patients will be encouraged to drink, which we provide for you oftentimes to drink in the night before in the morning of your surgery. So if you don't have diabetes, the route is to take 2 bottles of recovery drink or a pre-surgical drink, and you'll drink them between dinner and going to bed the night before. Then there's another bottle that you'll drink actually on the way to the hospital. So the goal is for you to drink it 2 hours before your surgery, which is what time you normally arrive at the hospital. We also talk with you about nausea prevention. So we give some nausea prevention medication so that that isn't something that's holding you back from moving on in your life. The anesthesia doctors have a protocol that they follow as well. That is their department in the world of medicine has discovered has made recovery as easy as possible. So they adhere to that as well. We keep you nice and warm in your initial recovery and keep the fluids at a place where your hydration status is good as well. We try to get you up and walking around. We try to get you eating or drinking as soon as possible. We talk about the different routes that we're keeping control of your pain as much as possible. There's no way to have surgery and not have some pain. It's just impossible, but we would like it to be as minimal as possible so you can get back on your feet. And then we talk to you about eating afterwards to keep your sugars on track. So that ERAS or ERAS has been around for spine surgery and colon surgery in town for many years. The gynecological world has jumped in Muskegon over the last 2 to 3 years. And so now it's just part of our regular process to try to get everybody feeling as good as possible. So that is the end of my little route of introducing you to surgeries. We talked in the beginning about that, cross your fingers, possible MAC for recovery, where we have a light level of anesthesia. Oftentimes I tell people it's similar to when you have a colonoscopy for the level of anesthesia that you get. If you have that MAC level of anesthesia, you'll go immediately from the operating room into what's called phase 2, where your family will join you very shortly. And then when you're feeling ready to go home, you can leave from there. Can't drive for 24 hours, regardless of how you're feeling surgically because of any anesthesia that you get. When we moved into those general anesthesia surgeries, the general anesthesia goes from the operating room into what's called phase 1. So phase 1, you'll be there for an hour to an hour and a half while you wake up with the majority of other patients who also are waking up. And then after you've gotten yourself to where you're awake enough, you'll go into phase 2, and that's when your family will join you. We have some criteria there that you have to meet before you can get out of there. But I hope that this has given you a little bit of an overview of some of the common gynecological surgeries that we do, as well as a little insight into recovery. Obviously, your surgeon will talk to you beforehand, both at your visit, also right before surgery, to kind of tell you a little bit more about what to expect. But in general, this gives a little blanket there. So I'm going to ask the moderator now what sort of questions she has prepared for us. And if you guys have any questions and you're on right now, you can toss them at her. Or if you're watching this in a recorded fashion, I'm sure she can get those questions to me so that I can help you out with that.
Yes, thank you so much. As mentioned, we're going to move into the Q&A portion. If you haven't had a chance to use the Q&A chat feature down at the bottom of the screen, you're welcome to do so. And then, as I mentioned, I did receive several questions through email, so I will jump right into those. Dr. Sakiga, I did try to organize them, so I apologize. But
I'm not worried about it.
Okay, perfect. The first one is, when would a full hysterectomy versus a partial hysterectomy be determined? What are those deciding factors?
So that is something that we would talk about in the in the visit to figure out what the goal and uh, risks and benefits are. So remember back to that picture. Again, I think this is part of that nomenclature thing. So a full hysterectomy would be recommended in anybody who's getting a hysterectomy, a total hysterectomy. So we usually use total instead of full, but it's the same thing, just potato, potato. And that would include that cervix. So rarely do we encourage leaving the cervix there unless it is needed for some other procedure, which we could always talk about as well. So in general, most of the time, if people are coming to me for a hysterectomy, whether it's for painful periods, heavy periods, pathology that's present, what we're talking about is removing the cervix and the uterus, that whole balloon, including the blow into hole. um, and again, some ovarian cancers are starting in the tubes, so we would take the tubes with it. So that would be your total hysterectomy with bilateral salpingectomy. Whether or not we take the ovaries would then add on that word oophorectomy, whether it's a left oophorectomy, a right oophorectomy, or a bilateral, taking both of them. If we don't include the ovaries in the pathology that we're removing, then the hormones will stay the same in a patient's body. Their main blood supply comes actually from your sidewall, which is a cool embryological thing because your ovaries actually started up in your abdomen. And then as you were formed as an embryo, they drop down into your pelvis and they drag with them their main blood supply. They do have a small blood supply that goes to the uterus, which obviously if we're removing the uterus, we have to take out, but their main blood supply comes from the sidewall. So we can just leave the ovaries in place with their main blood supply and then not have a shift in the hormones. So if we're a long ways away from menopause, we often encourage that unless the ovaries are part of the problem. And then we can kind of tailor that based on what the pathology that we're concerned about is. If we take the ovaries and we disconnect that blood vessel as well, then there will be no more hormones left in the body. And we would want to talk about hormone replacement or dealing with some of the symptoms that are present. So a lot of things go into it, but it's all part of that conversation that you have with your surgeon beforehand.
Perfect. Thank you. And I think that actually answered the next question regarding will hysterectomies affect my hormones and menopause? And so I think you did touch on that.
There are some studies out there that show maybe if people have had a hysterectomy, then they may go through menopause a little bit earlier. Depends on the study that you read. Some say it doesn't make a difference. Some say maybe a year earlier, and others say maybe up to 3 years sooner. So the average age in the United States to complete menopause is 51. So I'm sure everybody who is watching this or watches it later is very well aware that perimenopause is a thing. So perimenopause is when that ovary starts working less well, but it's still working. So you haven't gone all the way through menopause, but you're in the quest to get there, which does decrease and change some of those hormones as well. So perhaps what we're seeing by cutting that blood vessel to the uterus, that small blood vessel, maybe we're seeing that perimenopause is more notable, or maybe the studies that were done in the past didn't take into account the perimenopause status of women. But so maybe won't make any difference. Maybe it'll increase or the menopause transition by a little bit and decrease that age that it happens. But in most cases, we don't notice a difference if we were to do like blood work to identify the hormones in the ovaries, as long as they're still in place and they still have that blood vessel there.
Thank you. Next one is regarding pelvic organ prolapse. What would be the signs that somebody should that they might be concerned about this and should talk to a provider?
So there's all sorts of things that can prolapse in there. The most common that we see in women is the infamous leaking urine when you cough or sneeze or laugh really hard. In most cases, that is a relaxation of the urethra, which is the tube that goes from the bladder to the outside world. So God gave us a little kink in there, kind of like a kink in the garden hose, so that when you cough, it's like turning on the garden hose real quick. If that kink is there, nothing should come out. But nature, babies, gravity, pushing to poop has released that kink. So when you cough and sneeze, it can squirt a little urine. So if you're having incontinence, either when you cough and sneeze or something else called urge incontinence, which doesn't have to do with that kink, where you are having leakage of urine. It'd be something to bring up either to your family doctor or to your gynecologist so that we can get you educated on what we think is going on and maybe get some testing done. So urinary incontinence would be one. If the uterus, bladder, and rectum are prolapsing enough to cause issues, a lot of times the sensation that people talk about is more visual. So they go down to wash when they're in the shower and maybe they feel something down there that hadn't been there before. But I do think that since women are getting pelvic exams and breast exams every year for, breast cancer risk and just kind of, I'm a girl, I need to get checked out, that is a good time to ask if the physician doesn't bring it up. So in most cases, women have a mild amount of prolapse just because we walk on 2 feet. Gravity is rude to us. It's rude to our under eyes. It's rude to our breasts. It's rude to our uteruses as well. So if there's a small amount of prolapse, we don't usually bring it up unless a question is asked, but you can ask that. You finish with your pap smear, you finish with your exam and say, so do I have any prolapse? Or before the exam gets started, say I heard this lecture about prolapse or whatnot, and I'm curious, where is my prolapse at? And that gives us a chance to educate you on things. Just simply having prolapse does not necessarily mean anything needs to be done because, like I said, most women have some level of it just because that's what gravity does to us. But it is worth bringing up in a conversation if you're having any complaints or concerns, or just out of curiosity. Hey, where am I at? What does it look like? Should I be worried about this? Should I be doing anything differently? The thing that can affect prolapse a fair amount in a bad way is chronic constipation, which unfortunately women have. I think more often than men, although I don't chat with a bunch of men, hence why I'm in gynecology. So that does open up a conversation for what is a normal bowel movement? What should it look like? How often should I be going so that I can avoid having that for the rest of my life or making it worse? So any of those conversations or just pure curiosity at your annual is a good time to ask about it.
Thank you. The next question is regarding pelvic floor therapy related to organ prolapse and what your thoughts are on that as part of a surgical journey.
I think that it should belong in the pre-surgical journey for anybody who's having any complaints down there. Obviously, outside of menses complaints, because pelvic floor therapy is probably not going to help with the volume of bleeding that comes out of your uterus. But anything that has to do with discomfort, whether it be discomfort during periods, discomfort during sex, these are conversations that we talk about. Any of these prolapse, the urinary incontinence, we can see some amazing outcomes non-surgically with obviously no risk because you're not having surgery through pelvic floor rehab. Now, pelvic floor rehab is what we call the physical therapy. And the rehab providers have not only gone through general rehab training, but then they feel a drive towards caring for women in such a way that they take extra training to learn how to do this. So you're not going to have a pelvic floor therapist who isn't committed and devoted and wanting to go down this route, which I think is important because it's such an intimate sort of physical therapy. We're not just dealing with a shoulder like a lot of physical therapists experiences for patients have been, or a hip or an ankle. We're dealing with the vagina, which is a very private area and it's a very intimate exam and exercise situation. But these providers are very devoted to this and they stay on top of education and training so that they can really help women to live the best that they can live. And we see amazing results with that in the realm of incontinence, discomfort, pressure feelings, all sorts of things without the risk of surgery. We have some really good ones in town too.
Thank you. The next question is regarding endometriosis and when is surgery considered and what surgical options are available?
So unfortunately, there is not really a non-invasive way to fully diagnose endometriosis. We can chat about it, and there are some triggers, like red flags for, ooh, this girl might have endometriosis. So that would be like a clinical suspicion for endometriosis. There are some imaging findings that we might find on an MRI or an ultrasound that might suggest, again, that it could be endometriosis, but without actually visualizing it and potentially removing it and sending it off to pathology can we 100% say that that's what it is? So in the journey that we have for whatever the complaints are, whether it is pain, painful periods, pain with sex, heavy periods, irregular periods, whatever the complaint might be, we talk about uh, where some of those red flags pop up and whether or not it's worthwhile for us to investigate, to physically see, and then hopefully treat the endometriosis that we find. So that is done during a laparoscopy. We'll roll back in our memory to that picture of that cut down the middle person with the camera going through the belly button. That's a laparoscopy. When we shine that camera in there, we can look down towards the uterus, the ovaries. We often look up on the abdominal wall. We look down at the covering of the bowel, the liver, the diaphragm, because technically endometriosis could affect any of those places. So we look around with the camera, we take pictures. If we do find some, I usually have conversed with patients beforehand about, if I find something, can I take it and try to treat it? So if we find endometriosis, we'll put in those extra holes like we talked about for the hands, one to pick up and one to remove or cauterize the pieces of endometriosis that are there to try to help with the symptoms that are going on.
Thank you. The next question is in regards to the Da Vinci robot, and when would you use the robot versus just a regular surgical procedure?
So I think that in a perfect world, we would use the robot all the time because of the ability to go from just looking to acting. So if we have somebody with known endometriosis. So we've already done maybe we call it straight stick if it's not clicked into the Da Vinci. If we have a known diagnosis of endometriosis, so maybe they had a diagnostic laparoscopy beforehand and we found it and we removed it and we're going back for maybe a hysterectomy on that person or more invested removal of endometriosis. So maybe the doctor said, I started with a diagnostic laparoscopy, I removed a bunch of endometriosis, I couldn't get it all, and then we decide to return at a point. Or if we're in for a longer surgery like a hysterectomy, we see very similar incisions because it's whether I'm clicked in or the robot's clicked in, it doesn't really change much. But we have the availability to get down into some deeper spaces safer, or if there's scar tissue from maybe like a previous ectopic or multiple C-sections will cause some scar tissue, other bowel surgeries that maybe have been done for Crohn's or whatnot, then it gives us a bit more of a fine dissection. Now, there are a fair amount of surgeries that don't need that elevated level. Like I said, in a perfect world, if we had 50 robots in here and we could just pop on real quick, that would be, why not, right? But in most cases, things like removing ovarian cysts, doing a diagnostic to see if someone has endo, removing some basic found endometriosis, removing the tubes for that opportunistic self-injectomy or for fertility in a tubal ligation, which we don't ligate anymore. We remove the tube because of that ovarian cancer risk. Then a straight stick laparoscopy is very much sufficient for those situations. It would be for longer surgeries. Prolapse surgeries oftentimes are done with the Da Vinci because we're getting into some other spaces and some longer surgeries. Prolapse surgeries are often a lot longer than just the basic hysterectomy.
Thank you. And the next question is asking, how will surgery affect my sex life, either improving or I guess what it would be improving?
Right. So I think that there isn't probably a standard answer to that because it all depends upon what we're doing the surgery for. The biggest concern that women often have is in relation to sex drive. And sex drive is affected by, unfortunately, in women, a million things when it comes to relationship status and stress and sleep and weight and energy and all sorts of things, but also hormonally. So the example that I give to people is imagine just that we're mammals. In most cases, mammals only have sex when they're trying to procreate. So they're trying to create babies. And as your hormones drop because your body is realizing that you're no longer in charge of populating the world, a little bit less of those hormones are secreted. And so then the drive to repopulate the world goes down as well. So when we start affecting the hormones, we can affect the sex drive, but nature is doing it on its own in most cases, unfortunately. So we're all kind of working together as a team with our partners and with ourselves and with our gynecologists and with our primary care doctors to try to make everything as good as it can be so that we're working with the best situation possible. So you can see where if the ovaries are starting to decline in the hormones that they're secreting, if we take the ovaries out, we have the potential for affecting that in a negative manner. So that will all depend upon what the ovaries are doing on their own and how big of a difference it would make. If I had a 30-year-old and I removed her ovaries, there's going to be definitely a potential for changing that hormonal level compared to somebody who's 60, whose ovaries had stopped working and creating a bunch of hormone probably 10 years before that. So that's all part of that huge conversation that we have about total hysterectomy, oophorectomy, self-injectomy, the device that we're going to use, open versus Da Vinci versus vaginal, and then what that will mean for sex drive in general. Now, because that is just one part of it, and that's the ovaries, the rest of it is so multifactorial. There are some people who have very painful sex because of their uterus. So when we remove the uterus, that changes that. And who wants to have sex if it's painful? So if we fix that pain, then their sex drive automatically goes up because then they're back into where it feels good instead of where it's painful. So that's a place where it can definitely change things for the better. We also have a period of life where we're having our periods. And if that is affecting our sex life, if we're having a 14-day period each month, obviously that shortens the window and your drive is not necessarily as present when it's messy. Although sometimes that doesn't bother people too much, but it's all part of that conversation that we have beforehand. Now, in the case of surgeries, depending on the surgery that you have, you may be asked not to have intercourse for a certain window of time because of healing. So the longest would be around 8 to 12 weeks after a hysterectomy because the stitches where the cervix used to be and are no longer there need time to heal. So that's part of the conversation and evaluation and post-op evaluation that we talk about patients with. But you can expect probably an 8 to 12-week window there of not having intercourse until those heal up. So that's going to be a struggle, but we just prepare you for it. We prepare your partner for it ahead of time, all the way down to things like a hysteroscopy D&C. We usually ask you not to have sex for a short period of time after that because we've gone into that cavity and we don't want to increase infection risk.
Thank you. The next one actually, I think relates to some of that, is I understand that all surgeries have risks, but what is the biggest risk factor for gynecologic surgeries?
I think all surgeries, whether they're done on your bowels, whether they're done on your bladder, they're done on your gynecological system. Unfortunately, bacteria is our biggest opponent. So infection risk, which is why that enhanced recovery that we talked about during the ERAS or ARAS discussion exists because we're trying to mediate some of that. So we want to have a decreased risk of infection. So infection is one during the recovery. Bleeding, because now we're cutting into things. Anytime you cut something, it's going to bleed. So then we have a bleeding risk that's present. In the gynecological world, when we're getting down, like let's say in a hysterectomy, for example, the bladder actually is attached to the anterior wall of the uterus. We have to peel it off. So obviously the bladder is at risk. There's a lot of different processes and procedures that we do to be extra cautious of it, but we obviously don't want to damage the bladder. There's also a tube that runs from a kidney to a bladder that empties urine into there. Those can be at risk during surgery. And then you saw in that picture of the body cut in half how the bladder was right on top, then the uterus, and then your rectum and your bowels are all there together too. So there's always a risk of damage to that. You also have to get put to sleep, which anesthesia is pretty darn safe, but there's always a risk with anesthesia that just exists because we're putting you to sleep and then waking you back up again, happy and healthy, usually, in most cases. But I would say bleeding, infection, damage to any of those things, the tube, the bladder, the bowel, anything that's in there near what we're working with. And then anesthesia risk would be the top four. They are pretty low, all of them are. We do preoperative antibiotics in most major surgeries. The more minor ones we don't have to because of the risk that's documented out there. Anesthesia is pretty darn safe. We all work very hard to have you feeling as good as possible and back to your life.
Thank you. The next question is in regards to cancer. It says cancer was mentioned, and I'm wondering if there are any screenings or things that are looked for in cervical cancer or ovarian cancer.
So, as a gynecologist, the places, so if you come to your gynecologist for just your gyne exam, that's your bladder, like a quick feel of, but we don't look in it, obviously, because it's protected in there. Your cervix, your vagina, so that's the tube that goes from the outside world up to that cervix, the vulva, the ovaries, which we'll talk about here in just a second. And then we usually do a breast exam as well and talk about mammogram screenings if lumps are found. And then we refer you to the appropriate physicians there. So as we look at that whole world, some of it is during screening, which we'll touch on, and some of it is due to complaints. So if you come to me saying that you're having nipple discharge or you found a lump on your breast, then I will do an exam, we'll order the proper imaging and get you sent to the proper physicians for evaluation and then, if need be, treatment. Same thing goes in the vaginal area. When you're having your yearly exam, we do look at the cervix or where the cervix used to be if you've had a hysterectomy. We look at the tube up there, the vagina. We look at the vulva. And then we oftentimes do a bimanual exam, which is when we insert two fingers to feel. So we press on your abdomen and feel the ovaries on each side if they're able to be felt. So if we find something during screening, so we feel something in there, we see something, we'll talk about having that closer evaluation done and maybe a biopsy. So if it's like a spot on the vulva, we would talk about taking a look at that, biopsying it, sending it off to pathology. Same thing goes inside the vagina. On the cervix, your cervical cancer screening is your mainstay, which is known as a pap smear. Now, throughout my career, my ish years of my career, that recommendation for screening has changed a lot. So we're now in a place where we don't recommend cervical cancer screening until age 21, regardless of when people had intercourse for the first time. Now, this is just screening, remember. If there's any complaints, we might change that. We'll circle back to that in just a second. But so your pap smear would be starting at age 21. It's then performed every 3 years if you're under 30, if they're all normal, and then every 5 years if you're over 30, until age 65-ish, depending upon risk factors there. So in the low risk category. When we do the pap smear, we take a little spatula and we swipe across the surface of the cervix, and then this teeny tiny little circle looking brush to go inside that donut hole. We'll go back to that picture that looked like a donut. Remember, some of the cells on the inside of the donut we can't see. So we brush a few out of there and then send that off for a pap smear. The pap smear itself is just screening. It's not related to complaints as far as those years and the timing that goes. If people are having irregular bleeding or discharge, or when we look at it in those other in between years, because you're not getting an exam every 3 or 5 years, you're getting an exam every year. We just aren't swiping or brushing every year. Then if we see something that looks concerning, we might add a pap smear in there sooner because we're like, that doesn't look right. And sometimes it's completely normal. It just didn't, it was the timing of someone's cycle or what discharge they had or whatever. So we do sometimes increase that screening evaluation. So that's for cervical cancer. Vaginal abnormalities, vulvar is mostly visual, or if you guys have a complaint that we address and look at. Same thing with breast exams, screening every year. And then if you guys have a complaint, we change our story there. And then the screening mammograms. So ovarian cancer is the biggest struggle that we have. If we have people who have family history, that changes our story a little bit too, because we might add in some earlier testing in the form of a test that I use is called Empower. So Empower looks for genetic markers that could increase your risk. That might change our screening from its general. But in general, we're doing that bimanual exam every year to make sure that the ovaries feel the size that they should feel in your age group, which is different depending upon your age group. And then if people have complaints, so the most common complaint that leads us to increased surveillance is bloating or pelvic pain. So if you got bloated because you just had a McDonald's cheeseburger and then by tomorrow you're better, that's not what we're talking about. We're talking about unrelated to diet, kind of persistent feelings of things that aren't changing, or pelvic pain. That would be something to bring up to your primary care doctor and to your gynecologist. Our screening for ovarian cancer is not fantastic, but it is in the form of imaging. So we would get an ultrasound usually, and then if need be, we could look into some other screenings like CAT scans and MRIs as well. But the CAT scan is not great for the female imaging. Ultrasound is really good. And if we find something that looks concerning, we would move forward with our next step, whether it be to repeat the imaging after 3 to 6 months to make sure that it wasn't something concerning or persistent, or if it's concerning enough, we might have you meet with our gynecology oncologist, which unfortunately we don't have any in Muskegon, but they're right down the road in Grand Rapids. So we have two great groups in Grand Rapids that would take a look at the images, the story, and then potentially move forward with surgery if it was something that was deemed not safe for us to do here in a cancer sense. So anytime women have things like early satiety, so that's where you're not hungry, maybe not again temporarily, but to the point where it's causing you to have unexplained weight loss, bloating that's not related to your diet, or pelvic pain, then you should communicate that to your primary care doctor or to your gynecologist so that we can move forward with that evaluation.
Thank you. And I think this is our last question. It is, what is the average wait time to get in for surgery, or is there any risk in delaying surgery?
So we'll start with the risk in delaying surgery. Again, I think that's part of the conversation about why we're doing it. So on one end of the spectrum, maybe we have somebody that we have some concerns that there are cancerous cells present in any of those places, in the uterus, in the cervix, in the ovaries, which we didn't talk about in the previous thing. The uterus can also become cancerous. So that's a thing that's evaluated and discussed during your annual exams as well, as far as risk factors and complaints. But if we had something that was concerning for cancer, we would move very quickly towards finding out if that was the case. So that's with the imaging, with sometimes biopsies, things like that. If we do find that cancer is present and we send you to Grand Rapids to the cancer doctors, that window is very short. They're very good at getting you in quickly and getting you in for surgery because now we're dealing with a cancer. Anything that is non-cancerous, we have to evaluate together as a team on how much is affecting quality of life versus danger. So if we're in a dangerous situation, someone is bleeding so heavily that they're bleeding to death from their uterus, we're going to get that uterus removed as soon as possible, or ablated or treated or something, because they're in danger. And then we get to quality of life. And then we have a whole conversation. A lot of times people have had crappy periods that have been affecting their quality of life for years. And now they're finally sick of it and they're over it. And then we talk about, okay, let's see what works for your schedule to take that time off of work, to take that time off of having intercourse. Remember, we talked with the hysterectomy, 8 to 10 weeks. We probably don't want to do your hysterectomy 3 weeks before your anniversary because that would interfere with some of that sometimes. Or if that works for your job and being off of work, then maybe we still make that decision. But it's a conversation where we try to make it as good as possible for your quality of life, your work schedule, your kids' sports schedule, and then having a ride to surgery, having someone to help you out with some things. All that stuff is taken into account. In most cases, a cancer surgery, if we talk about standard of care, we need to get that diagnosis and that treatment done within a 3-week period. So if somebody's having a complaint, we need to biopsy it or evaluate it. We need to get that done within a few weeks. And all of the gynecologists in town, they might have a long wait for a yearly exam because we're just doing maintenance. It's like your oil change on your car. If you're a couple hundred miles past your oil change mark, it's not probably going to make a big difference. But if you are having a problem, if your engine is skipping or you have smoke pouring out, you can't wait to be a little late on your oil change. You have to get in for a service appointment. So all of the gynecologists in town are very good at making an availability for a service appointment. So if you're having a problem, please describe that to the schedulers and say, this is not just a oil change. This is a problem and I need to get seen right away. And we will work to get you into the schedule, whether it's to be seen in an early slot. We make a slot for you. We rearrange patients to make that happen. Your gynecologist will get you in to be seen for that problem visit sooner than later. And then once we decide the severity of it, dangerous, quality of life, your schedule, then we can work together with the surgical department to try to get that done in a timely fashion. Now, the little hiccup in there is that the insurance company also plays a role in that. Not always my favorite, but we might have to delay that timing because we have to submit the information to your insurance and make sure that they're going to cover it. And then you have a chance to speak with them too about what your out of pocket cost will be. How does that work with your finances? So there's a whole bunch of pieces that go into it, but we try to do that as a team to figure out, what the expectations are for the best outcome for everyone.
All right, well, that wraps up all of our questions. Thank you so much to Dr. Sickinga for the presentation and the very insightful Q&A. And thank you to everyone who has joined us, and we hope everybody has a great day.
Thanks, guys. If you need anything, you know how to get a hold of me.